uh, NC Survivors Union, Whose Corner Is It Anyway? And most pertinently here, the COVID-19 and Substance Use Data Collaborative. And I'm speaking to you today from the tribal land of the Mohegans, the Chippewas, and the Algonquins here in Western Massachusetts. Welcome to the second part of the collaborative's 6-session series, Confronting the Drug War, Drug User-Oriented Harm Reduction and Drug Policy, in which we host activists who use drugs and harm reduction researchers to discuss drug policy reformation, structural inequities in drug treatment and harm reduction systems, the deconstruction of the disease model of addiction, and alternate ways to think about drug use. This series is co-sponsored by the Yale Program in Addiction Medicine, National Survivors Union, the UCLA Center for Social Medicine, Drug Policy Alliance, Ford Foundation, and the School for Advanced Social Studies program, D35, Drug, Social Sciences, and Society. So today we've invited Kali Sedgmore, Nick Voiles, Zara Snap, and Ryan McNeil to join us in this roundtable to talk about their experiences researching, advocating for, and implementing safe supply. Safe supply defined very broadly, as you'll see. And we'll begin by having the panelists introduce themselves, then go on to have them answer 6 roundtable questions with some discussion among themselves, and then we'll be able to end with Q&A, so please do type in questions into the Q&A box as you think of them. So starting with Kali, if each of the panelists could go around and give us your name, your pronouns, your affiliation, and your past and current experiences with safe supply implementation, your journey into and your motivators for doing this work. And I'll just call on people after Kali goes so we don't have an awkward popcorning situation. So Kali, if you'd like to start us off.
Yeah, hi everyone, I'm Kali Sedgmore and I live in Vancouver, BC, and Safe Supply. I'm part of a coalition of peers dismantling the drug war. A coalition of peers. Safe supply to me means a lot of things. It's mainly we fight for stimulant user safe supply because a lot of stimulant users get left out of the conversation, especially in Vancouver, because it's all about OAT or different things like that. So safe supply includes illicit and medicalized safe supply. And it's something, yeah, I kind of got into it just because we're witnessing a lot of people dying right now due to the toxic drug poisonings in Vancouver, and it's upsetting because a lot of them are stimulant users who are getting cross-contamination and stuff like that. So it's a fight that we've been fighting for a while now, and it's something that's really needed because we don't need people dying.
Thank you, Kali. Zara, could you introduce yourself?
Thank you, Katie. So my name is Zara Snap, and I'm based here in Mexico. I have an organization, I'm a she, her, and I have an organization called Instituto RIA, and we do research and advocacy on drug policy reform around within a social justice framework. So we believe that drug policy reform is a key part of getting to communities that are safer, communities that are more peaceful, and then in fact, substances have lots of benefits as well as some risks. And so we like to talk about all of the issues. And obviously, we've come to this place of safe supply really from an idea of how do we incorporate communities that cultivate or that produce plants and psychoactive substances. How could they be part of the conversation as well? How could they be part of the production chain so that they can live a dignified life and not be living in clandestine conditions, and to have their human rights also protected? So we really look at the whole production chain, not just consumption, although we also talk about that, but also how do we really include those communities and also people who are participating in the distribution, because that's a key part and something that's much needed, and also that we need to be destigmatizing and being able to really incorporate into the conversation. So, and I also come from a place of privilege, being a white woman, being able to talk about these issues, being able to talk about being a person who uses drugs, which is something that a lot of other people aren't able to do because it might impact their professional or personal life. And luckily, I'm able to have jobs that allow me to talk about this openly. And really my motivation is around justice, around that prohibition has been based on lies and fear and social control and discrimination and discretionality. And so how do we really get to a place where we can repair the harms? And I believe that we can repair the harms through legal regulation if we have a social justice focus. Thanks for the invitation as well. It's an honor to be here with all of you.
Thank you, Zara. I'm really impressed by the holistic view you have of the entire process. Nick, could you tell us a little bit about yourself and your journey toward and motivation for participating in safe supply work, however you define it?
Yeah, I want to be really clear about safe supply when we use that term. The term safe supply, it's kind of bandied around because of what they're doing in Vancouver and other places. For us, the safe supply is methadone because we have to. We have no other choice. Under the current structure of our laws, we don't opt in. We don't have a safe supply to opt in. You know, everything's adulterated or it's, garbage. So when we talk about safe supply, what we're saying is, in the context of our current environment, it's the safest supply we can get. And unfortunately, even for that, we work tirelessly just to get the small pieces from the table that they allow us, I come here because I'm a lifelong methadone user, and I truly believe the molecule, the magic's in the molecule. There's too many structures around methadone that are curbing it, instead of letting it fly free, if it were, and watching what a dazzling thing methadone can do just on its own. As far as the safe supply, at the union, a lot of us are clinic, go to the clinic or getting methadone one way or another. So it's an easy no-brainer. When we discussed like what our top priorities were, methadone was always at the fore. And we've even laid out like ad nauseum how to fix it from a patient's view. We went so far as to research it and research ourselves and place what fixes, not just here's the problems, here's the fixes as well. So that's where I come to this work from, and that's why I'm interested in discussing methadone as a safe supply until we can discuss fentanyl as a safe supply.
I was going to say that was a Freudian slip, but maybe what we needed to launch the discussion.
Yeah.
And finally, Ryan, if you don't mind telling us a little bit about yourself and what brought you to this work.
Yeah, so I'm Ryan McNeil. I'm in the Yale School of Medicine, Public Health and Anthropology. Most of my work to date's been in Vancouver, where I've been really humbled to have the opportunity to work with drug user organizations for more than a decade, which has involved organizing around these issues. And really, for me, safe supply, first, on a basic level, it's legal access to a regulated market of drugs that are criminalized. And, at a basic level, I understand it is central to our objectives around social and racial justice. We can't get there when we criminalize and specifically horribly and prejudicially police, especially people who use drugs of color. And that it's central to how we can promote social justice more generally, because we can't get there when we criminalize people on the basis of things they put in their bodies. And, further to that, and just to foreground, for me, so much of my thinking around this really emerges out of just this unrelenting mass casualty event we've been having, where we're just losing tens upon tens of thousands of people to a overdose crisis fueled by the war on drugs. And so for me, safe supply can't be separated out from the broader need and call for social justice. And I appreciate Zara bringing up from production on through to consumption and every step in between.
All right. And now we'll get to our roundtable questions. So each question will be answered by about 2 or 3 of the panelists, with opportunities for moderated crosstalk among them. And for the first question, we'll have each person in the panel very briefly address this topic, which is, can you introduce the concept of safe supply as you understand it to the audience? And I will just go from right to left on my screen and start with Zara.
Oh, okay. Well, we talked about this a little bit yesterday, And it's a big question on whether safe supply is just a change in semantics, or if we're talking about legal regulation as kind of the same piece. I think it's been brilliant to introduce the concept of safe supply, because it's recognizing that right now the supply, as my colleagues have mentioned, has been adulterated or substituted and is toxic. And so it's about recognizing that people should have a choice in what they want to put in their bodies, and that they should have security around what that looks like. And that you aren't, it's not a flipping of the coin, or Russian roulette. And so that's where, we in Mexico talk about safe supply or secure access. But we really talk about it within a framework of legal regulation, because we want to talk about the whole production chain. So for me, I guess it's more of like a question: is safe supply the same as legal regulation, or do we see differences, and what might be those differences?
Kali?
Safe supply to me is both illicit and medications for safe supply, and it's also just giving people what they want and what they need, and just knowing that people are going to use drugs no matter what, and then that includes youth and that includes adults. And safe supply is also just a way to keep people alive, so we're not losing more people. It's giving people what they want, what they need, just so they can stay alive.
Ryan?
Yeah, I mean, I think it's been beautifully put so far. The only thing I would add to that is, I often think about safe supply as something that extends beyond a legal regulated market, which to me often has a bit too much of a libertarian bent that loses kind of the central thrust around social and racial justice, the need be at the heart of this. And I think in conceptualizing safe supply and foregrounding that, the existing illicit supply, it's characterized by things that are toxic, that it creates a further space for thinking through how to do this in a way that really matches up with what people need, and creates a space for things like thinking about compassion clubs in the context of providing access to regulated drugs, and things that can be further responsive to, structural vulnerabilities like extreme poverty that impact so many people. The one caveat I would say with that is, certainly, so my team's been doing work around prescribed safe supply models on a continuum from, injectable hydromorphone and diacetylmorphine or prescription heroin being used as treatment, on through to, access to prescriptions as guidelines have shifted, to hydromorphone distribution programs running out of overdose prevention sites. And I think the crucial element here, and I think Nick captured this really well, is in the context of the supply being toxic, whatever it is that can be an alternative to that can be thought of as safe supply, or certainly it's often framed as safe supply by people accessing it. So all of this is to say it can be a lot of different things, but centering justice in it is something that I think is an important carry through or thread for how we go forward.
Thank you, Ryan, for that. I think it's really important to broaden the conversation beyond sort of the strategic, medicalized, or regulatory systems that we think of as options when we first confront this issue. Nick, do you want to go and finish us off for this question?
Yeah, all of what you said is I mean, there's not much to say more about it. I mean, it's the idea is, what can I do to make me and mine safe for right now, and how can we push it forward? And I really like what Ryan says. Like, we really have to, like, I've been thinking a lot about this lately, that like, okay, we're pushing back. We call ourselves drug users, human rights advocates now, because harm reduction kind of doesn't fit some of the stuff we do. And if we're doing that, how much and how far and how strong are we pushing that we realize this affects Black and brown people way more than it does us? And how can we then aid that without overtaking, without virtue signaling, how can we aid that position? So like, when we talk about safe supply, like, it has to be equal across the board, and B, it can't negatively affect somebody else to positively affect methadone users. You know what I mean? And there's a lot of times that like these things will happen, and the only people they help are rich white people. So like if we're not talking about a supply that's regulated and also given in a way that's just as equal in the middle of Watts as it is in Wisconsin, then we're not talking about anything. We need to go back and figure it out. Because if we don't drag all of us out of the situation, then we're just playing their game. You know, we're playing the same game we always play. You know, the throw the white guy. You know, nothing matters till a white guy dies. You know, and I think that's what we see, and that people have done a very good job in supporting a narrative of methadone as shackles. Methadone is holds you into one place and you can't get break free. So anyways, I just want to say that's what I'd add to all the beautiful things that everyone else said.
I really appreciate everybody really centering this discussion through a social justice lens. And I will move on to the next question, which is specifically addressed to Nick, but anybody else in the panel who would like to respond to his response or has any thoughts on the question can take on the mantle after he's done. And so the question is, what are the impacts and implications of defining methadone and other medications for addiction treatment as safe supply? And what does viewing opioid agonist treatment as safe supply mean when opioid agonist treatment access is so racially and socioeconomically stratified? Nick.
Yeah, I would say two things. I would say one, like I said in the beginning, what's really important here to understand is that the only reason we're using this as a safe supply is because that's all that we have right now. I mean, that's the key here. You know, we watch other countries set up safe supply that works wonderfully. You know, we know that there's been heroin therapy in England, you know, for decades, you know, and it worked great. The thing is right now we have a legal substance. You know, we're not even fighting for like a criminalized substance that can allow us not to die, right? So, I mean, very simply, you know, it will keep us alive. And I think the idea that people keep pushing is that just because we're settling for methadone doesn't mean that's the end all of our safe supply journey. But we need to at least have that before we can bounce forward. We all talk about the richness of having legalized drugs and you know, have pushing stuff like acetylmorphine and heroin hydrochloride and all these things, which would be great. I mean, it's a dream, you know. But I just think that what we have right now is methadone that we can't even get out of the clinic situation, you know, out of a culture of cruelty, you know. So unfortunately, the only reason that the union is so committed to this is it's the only one we have right now, you know, and we are committed to breaking down racial and socioeconomic divisions in the access of it. We're also really concerned, for example, of like the buprenorphine proliferation without parity in methadone, you know, and that's a huge problem for us. You know, if you look at it, most people are able to transition out of chaotic fentanyl use onto methadone rather than bupe. But we hear from people like some of our members who couldn't find a doctor to even prescribe bupe for in her neighborhood when she wanted to switch from methadone, and that concerns us just as much. So like the idea is that we have one drug that we know works. We have a drug that we know works well against fentanyl if used correctly, if leveled up in the dose as high as you can. And so if we know that anecdotally, and now we have evidence to back it, why are we not clearing this path for us? You know, I used to say one to rip across the rip out the clinic system, this culture of cruelty that like possesses us and chooses to do with us as they will, and cast it aside and build something new. I now think that we can't even get there that far. I think in fact we just need another choice. We need a choice that says, hey, okay, here's the clinic for all those people who need this. And then for the people who don't and just want to get their methadone, here you go. You go to your doctor, get your methadone, and go back. Hopefully by making two of them, we can study against them and find that like the treatment outcomes they give us on this side don't mean shit. And the ones they give over here, you know, that we take that are self-driven, you know, determinations mean a lot. Does someone else want to comment before I just rattle on?
Does anybody else want to comment?
I would jump in with something that I think Nikki pointed to quite nicely. I mean, if we think about methadone, if we think about, say, work we've done in the context where we've looked at like injectable hydromorphone or diacetylmorphine or prescription heroin, you know, we deliver these in such a paternalistic way, subjecting people to regulations that would not be acceptable in any other form of treatment for any other group of people. And we dress it up by calling it that, by saying that's how treatment is. And, the reality is we make these drugs treatment in ways that are horribly disruptive and constraining in people's lives because of how society more generally feels about people who use drugs. And, if we think about, I think the really great work the National Survivors Union has done around, advocacy around methadone and kind of unshackling it, around, work other groups have done around, I'm thinking of work back in Canada around, advocacy around, say, take-home dosing for prescription heroin or hydromorphone or, other things. It's really comes down to the medical system has really, alongside the state, monopolized responsibility and power in relation to what people can put in their bodies in ways that have done nothing but produce death and produce poor outcomes for people who want or need access to these things. And really, unsettling or decentering that really needs to be central of the push for safe supply. Because otherwise, we're just asking people to continue to subject themselves to systems that have been horrible to them and are horrible for them because of how they see them as people, which I think we see in, we see in decades upon decades of community experience first, and just to center that. But there's quite literally like a mountain of research at this point about how horrible these systems are. And yet, unfortunately, so much of how even safe supply has been advanced so far has really just been to reproduce the failures of these systems through paternalistic approaches that treat people who use drugs as children. And, central to work around safe supply is that advocacy around methadone, is that advocacy around so many different things, because that paternalism that's at the heart of it is part of the challenge to this whole enterprise right now.
And Ryan, to just draw your point out just a little bit, when Nick and I were talking last night, we discussed how when safe supply in the form of stimulants, in the form of shorter acting opioids finally becomes politically possible in the United States, what map will this new system have to use if we're still stuck in the clinic system, if we're still stuck with tertiary healthcare sites, totally isolated from the rest of the healthcare system, which are knee-jerk, draconian in their response to every single patient need. If we're going to have safe supply dispensing that looks like the methadone clinic system, then we won't have won a real victory at all. So thank you for bringing out that point about the need to get ourselves out from under the stain of these paternalistic systems in general. So the next question is, and I am going to aim it first at Kali and then see who else in the panel would like to respond. But Kali, can you tell us about your experience with underground implementation of safe supply and what its value is? In the absence of viable, easily accessible safe supply, what strategies can we use in different environments to create our own safe supply?
For underground safe supply, like it's really about disrupting the system. It's about doing things illegally and that could get you arrested, but it's about just challenging that and just doing it in massive amounts and just doing that with a group, like a reasonable amount group that's willing to do it, that are willing to stand on the line for that. Because it's like, for instance, stimulant users are still being affected by this and stimulant users are still being forgotten about. And it's really frustrating from the amount of death we've dealt with stimulant users is not okay. So a lot of times we're implementing, like getting crystal meth to people that need it and not giving them a prescribed safe supply of crystal meth, because crystal meth is a lot easier, is what people need, not just 40 milligrams of dextrogen and stuff like that. And so it's really about disrupting the system and about challenging the system and just fighting for what you need, because people are dying, and just by doing it, off and just by doing it, and just making sure that you're protected technically by having a large group of people, or just by doing it really quietly, are ways to do it, and just making sure that you don't get arrested. But it's also doing safe supply like that. Like we do a lot of handouts, like we do during anniversaries. For like instance, the 7 years the public health crisis has been called in BC. We're going to do we do handouts and stuff like that for stimulant users mainly. And it's about just disrupting the system and showing that these things could work if we had them, if we were able to do it better, I guess.
Thank you. Does anybody else in the panel want to respond?
I'll probably wait till a little bit later for my response. I just want to say that, like, you know, the idea is not fall short on me that the denial of MAT for one drug and the opting for another has extremely racial context. You know, yet again, we see the same thing, you know, and I just wanted to pop that in there.
And maybe we'll have some time later to talk about what underground implementation of safe supply looks like when we interpret methadone as our safe supply, otherwise known as diversion.
But we know, like, there's been times where we've had to take care of our own before, right? And the funny thing is when people talk about diversion, right, we don't see it with methadone. We see it absolute with bube. Like, I mean, unreal with bube. In fact, I don't know many people even take their bube, you know? But with methadone, the only time I've ever seen diversion is to help somebody not be sick, or is to take care of someone who's not got anything, because that person's going to care more than a shit system set up, you know, be a probation office with drugs, you know? And I just, yeah, sorry, it's just so fucking sad, you know. It's just like, it's a simple thing to pull this out from the reaches of these people, you know. It's like it's came into a context where it's big money now with Medicaid expansion. Everybody's jumping in. All these big corporations jump in because it's easy money. You know, we're what's called passive cash flow.
Yeah, I mean, in a context where the DEA itself has said that methadone diversion has fallen quite a bit since 2016, and yet the fear of methadone diversion continues to drive these draconian regulations and restrictions. When we know that what diversion actually is in the case of methadone, you know, is community care. Zara, sorry, I didn't see you earlier, please.
No, it's okay. I just want to add something on that, you know, here in Mexico, and one of the reasons I think I was invited to this panel is 2 years ago, we wrote a paper on what it would look like if we were to supply or provide opium gum and heroin from Mexico to communities that are currently using, you know, toxic supply of opioids, oftentimes adulterated with fentanyl, or anything else. And so we wrote this really thinking about what would it look like? Like, what would it look like if between Canada and Mexico, there was some sort of bilateral agreement, which is completely possible, where then folks would just have a wide range of products. So it's really up to the person to decide what they want to consume, and maybe they'll continue injecting or smoking some substances obtained from, you know, illegal markets or, you know, through heroin medical programs. But what would it look like if you actually had the opportunity to decide, I want an opium tincture, or I want to smoke opium gum? Really just recognizing that people should be given the broadest spectrum of possibilities, just like we are given when we decide to choose to use alcohol, for example. And so like, what would that look like? And one of our pieces of kind of working on this paper was having met folks who had been cultivating poppy here in Mexico, and just the obstacles that they face, both of moving product, of having to be the intermediary, And then some folks from Canada had also contacted me about whether they would be able to gain access to, heroin or opium here in Mexico. And so we tried that a couple of times to be able to provide that safe supply. But unfortunately, it was really risky because you're putting yourself in a lot of risk. Both folks here in Mexico, somebody from Canada showing up to a community in Mexico, you stand out. It puts everybody at risk because as Kali says, you're disrupting a system, and a system that is profiting on people being at risk and people dying, unfortunately. And here in Mexico, the government profits and the weapon industrial complex profits from having a war, an ongoing war. They sell us all our weapons, and then also people bring down weapons from the United States to Mexico. 90% of the guns that are found in Mexico were bought in the United States. So it's really one of those things that there's so many interests that are being preserved with the status quo, that this kind of community, non-commercial way of maybe thinking about this issue, or a way that would allow communities or families in Mexico who are engaged in this to be able to earn more money, is something that just kind of messes with that system that is working, in quotations, for very specific people, industries, groups, both state and non-state. And so that's where then, we think about, in the last 3 years, the cost of opium gum has fallen more than 80% for communities that cultivate. And this is obviously because of the influx of fentanyl. And so it's really a development piece also. And it's a piece that most of these folks are in extreme poverty, and they cultivate poppy in order to complement or supplement their other subsistence crops that they have. And so when you do eradication of crops, you are causing them to then be in debt to whoever gave them a loan, maybe to be able to put that crop. You are causing them to possibly be displaced from their community. So it's just one of these things where we're all connected. And so I think we in Mexico would have loved to create some sort of pilot project where then we could be sending, opium gum and heroin to Vancouver so that they would have a safe supply, but a safe supply that's also thought about how it's cultivated and that's well paid, so that the communities here in Mexico would be able to gain from that. And that then we're saving people's lives on both ends of the production chain. I mean, that would be the goal.
Thank you. Ryan, you've had your hand up for so long.
Yeah, no, that's brilliant. And Zara and Callie, I appreciate the focus on disruption and how the challenges inherent in that. And I would kind of further add to that, certainly I think one of the challenges more broadly as we think about legal and regulated markets is it's also disruptive to the criminal legal system, which certainly functions as this horribly self-sustaining system of structural oppression for folks who use drugs, and in particular, folks who are racialized or poor. And part of the challenge I find is so much of the frame of how we talk about drug policy is so steeped in language from those fields that it fundamentally challenges our way to even talk about safe supply at times, or talk about practices that have always been proxy safe supply. So as an example, Nick and Katie, I appreciated the attention to, how we think about diversion. Part of the challenges in how we talk about diversion is that we use the fucking word diversion, which is fundamentally a way of framing this that has been steeped in, moralistic culpability around the overdose crisis, or as things that are criminal. When, the practice has always been that so much of how we might think about quote unquote diversion is quite literally secondary safe supply, in the same way that we talk about secondary syringe exchange as a way to increase coverage. And certainly thinking about this, especially in the context of a toxic drug crisis, is I think a productive thing, but we fundamentally have a problem in how we talk about this and how we talk about drug policy more generally, that is a real challenge to carving out even a discursive space for safe supply.
it's really sad. They've done a really good job of scaring the shit out of people with methadone. You know, cementing all that drug data deaths or the death data into an intricate series of problems with methadone that really have never came to light. It always blew my mind. I never understood others that you can only get methadone in one place. And I think that they've done a really good job at setting up a shitty system that they can back. We just have to figure out how to get it either, placed in another place alongside it, and then maybe rid us of the actual place. But I mean, they've done really well.
No, and thank you both of you for challenging that propaganda, Ryan, as you say, on a discursive level, when what quote diversion is, at the very least, it's an indicator that access to opioid agonist treatment isn't broad enough. And essentially what it is mutual aid and community care. And Zara, thank you for bringing up the choice between opium gum and more and stronger illicit supply. I think, if we're thinking about this in a utopian manner, people should ideally have the choice between different potencies and different concentrations of their drug of choice. And in an ideal world, that's what we would be able to have, and fewer people would use the most potent option. Going on to the next question. So how do we reconcile different objectives like pleasure and safety, which are both objectives that different stakeholders believe safe supply is meant to achieve, when these objectives are framed as conflicting? And Ryan, if you don't mind tackling that question first.
Yeah, I mean, so this has been the challenge with what we've seen in prescribed safe supply. At best, for the most part, it's been a bridge for people. It's been something largely envisioned as something to ward off withdrawal, as something to keep folks from getting sick, or maybe to mitigate cravings. But part of the challenge in that is, if you don't match how you actually do a version of safe supply with like the actual life of how people use drugs, it's not going to fully work. And so as an example, so we've, my team's done, I mean, a lot of the work that's been done on prescribed safe supply models to date. And the consistent limitation has been that it's not quote unquote fun in comparison to the other substances that people use, or it's not enough. And Kali, I especially appreciate your insights here around the stimulant safe supply as it's been rolled out, but it's been a half measure. And that's a challenge. When we, again, seed ground how we think about safe supply to, overt medicalization, we frame it in a way that doesn't match how people use substances. In the same way that, if we were prescribing shitty booze to people as the only thing that they could work, I mean, people would not particularly like it. And that's been a challenge. And centering pleasure is central to how we think about this, because it's how people use substances. And certainly, I think the biggest failures that we've seen here have been especially in relation to stimulant use.
Zara, do you have anything to follow up on that?
Yeah, I mean, we had discussed this a little bit. I think it's important also that we are, and here in Latin America, we've been doing this a lot around that it's risk and harm reduction, but also how do you manage pleasure? In Spanish, it sounds a little bit better. Gestionar placer, which is really about everyone who uses substances. We use them because we think we're going to perceive some sort of benefit, that we're going to feel less tired, that we're going to be able to go through our day, that we're going to have a euphoric experience, that maybe we're going to have a mystical experience, that we're going to just feel good, that maybe we're going to forget something that we don't want to remember. There's all these reasons, and there's those great studies from Hayden, Emerson around that. But, we can also just talk to people to know that. And so I think that there's something about that in our societies, pleasure is a taboo subject. We're not supposed to derive pleasure from much. And now, because of the Industrial Revolution, and now maybe we're living in the, post-pandemic world of virtualness that, we're just supposed to be working and doing as much productive as possible. And then what does that look like? And so then really, like substances oftentimes give us the opportunity to take a deep breath, to just be with ourselves for a second, to maybe be in community, and those are all things that are not, that we don't really want to talk about. We don't want to talk about why people maybe don't have a sense of belonging until you find a group of people with whom you're going to use substances. And that can be alcohol, it could be tobacco. You go out and smoke a cigarette with somebody and then all of a sudden you have a connection. And so I think we can talk about some of the risks of using substances. It's important to be able to know that, to make informed decisions about our use. But it's also important to really talk about the pleasure that you might derive from that and how you feel. And that and what does that look like in other ways? How do you incorporate, endorphins into your life in other ways? But so we've really been trying to expand these definitions so that we can really incorporate a more nuanced perspective of why we use drugs and why people might seek to alter their consciousness.
Thank you so much for that. I'm going to move on to the next question because we are running short on time. And the next question hits on a theme that I think we've been circling around this entire time, which is opioid safe supply is often prioritized above stimulant safe supply, perhaps because of simplistic ideas of medical necessity, and perhaps, and let's face it, necessarily because of implicit racism. How do we prioritize stimulant safe supply? And Kali, would you like to lead us on that one? Kali? I think you're muted. You're muted. Oh, there we go.
There we go. There. Yeah, sorry about that. Anything around protecting safe supply is just by disrupting the system, making it, giving people what they want, giving people what they need, and stopping. It's really about stopping. That's the big thing that we're dealing with in BC, anyways, and I think America's dealing with the same thing. It's just like we really need to disrupt the system, make changes that way, and just if we get try not to get arrested, but it happens. And that sucks. And it's a very big racial thing too. It's like a lot of, for us in BC, there's a lot of white people that are doing this, and then indigenous people, I'm in the background. I stay in the background because I know my risk of getting arrested is more than some.
It sounds like you cut off on us for a second, but
and expect, this is their big thing that keep getting misapplied. It's just like they think that.
You're breaking up a little bit, but it sounds like your answer to the question in short is civil disobedience, which I can definitely get behind. Does anybody else want to take on the question of how we can prioritize stimulant safe supply?
Yeah, so I just wanted to comment that in 2017, after a 2-year process, myself, along with colleagues from Acción Técnica Social, which is based in Bogota, Colombia, we did a study, which unfortunately is only available right now in Spanish, but we're working on getting some of those pieces out in English. We did a perspective study, which was really around what would it look like to regulate cocaine in 2034. So really thinking about kind of these inflection points and what are the many different factors and variables that we'll need to be taking into account, which includes some of what a lot of what we're seeing. Our first inflection point was 2022, then 2028, and then 2034, which includes people buying drugs on the internet, which includes drug user organizations mobilizing, which includes an interest by beverage companies, for example, wanting to be able to use coca leaf derivatives in their products. It includes greater research from universities on the coca leaf and on cocaine and its uses. It obviously contemplates a differentiated regulation scheme where then communities that currently cultivate coca leaf would be allowed to participate in the market within a social justice framework. We also did, for example, a survey among people who use cocaine, primarily in Europe and in Colombia, in preparation for this study. And for example, we found that people are highly interested in getting cocaine that could be, in quotations, from a fair trade model or a fair market criteria, you know, and that 74% of the people who answered that survey said they'd be willing to pay more for their cocaine if it was cultivated under certain conditions. This recognizing that for a lot of people who use cocaine, like, you care about the clothes you wear, you care about the food you eat, and you also care about the substances you're going to use. And so all of these are factors, as well as factors which really bring us a lot of sadness, which is that social leaders in Colombia continue to be assassinated when they participate in substitution programs. So we really have to figure out how do you change these dynamics instead of thinking that if we continue to do the same thing, we're going to get different results. And so we really kind of did this forecast to try and think about that, to think about it from the Colombian perspective. But in preparation for that, we'd also visited Switzerland, where we talked to people from the government and also people who obviously use drugs in Switzerland. And so many of them were like, we don't want a medicalized model. We don't see ourselves going into a clinic to get cocaine because we don't think we have because we don't have a problem. And it's not a problematic use. And so, or any, you know, like, you just want to be able to go to a safe place to be able to get the drugs that you want to consume. And that was something that the Swiss government identified as problematic, because they were like, with people who use heroin, you know, we can get them to come in, we can get them to be part of a program, but folks are highly productive, and most of, you know, it's a diverse group of people. Anything, I mean, all people who use drugs are diverse, but they saw that as harder, because how are they going to link people in? But really, all we need to get these programs started is that there is a political will on the part of governments from cultivating communities. And obviously Colombia is the example of a country that has been most damaged by prohibition after 52 years of war, and a country that's willing to be pragmatic and to be innovative, which the Swiss have been with their heroin, medical heroin programs, to really think about how are we best going to meet people's needs, and hopefully not fall into a paternalistic framework. But, you know, if you were to accompany that study, we had a huge graffiti on one of the main boulevards of Bogota, which said "Coca regulada, paz garantizada," regulated coca, peace guaranteed, because we were really connecting it to the peace agreements, and that we can't talk about peace in our countries if we're not talking about regulating these substances.
Segueing from the really praiseworthy strategic canniness and complexity of that response, I'm just going to go to the last question, which is, in your opinion, what strategies lead to or can lead to the success of safe supply implementation in policy and practice? What are the social justice and policy implications of a shift to safe supply and a related regulated market along the continuum from production to consumption? And Zara, I know you're going to have a bit to say about the continuum from production to consumption, but maybe if we can start Ryan off on this question, maybe then go to Nick. If everybody has something brief to, if everyone has a brief response to this question, that'd be great.
Yeah, I mean, I think colleagues especially captured, you know, the role civil disobedience has played in advancing this. And I don't think we're losing that right now. Just because, you know, it's really typically been how we've gotten any advances with harm reduction and drug policy reform. It's from people breaking unjust laws. So first and foremost, that's where we are. Now, at the same time, like, look, I'm at a university. A lot of other folks are positioned, you know, in similar ways. Folks are located within health systems, have policy roles. People have to actually, like, I mean, I'll say brave as opposed to develop a backbone, but, like, you know, people need to advocate for this at every fucking level right now, because we don't. We hand wave around treatment. We talk about recovery-oriented systems of care. We talk about nominally harm reduction, which is often reduced to, you know, some fentanyl strips and some naloxone. We have a toxic drug supply. And every single discussion about this crisis needs to center that. And along with it, note that you address a toxic drug supply by replacing it. And we just need to have like a consistent through line in the advocacy around this across every sector and every actor involved. And also fight. There are bullshit arguments coming out about safe supply or regulated markets as people try to retrench the drug war because it's advantageous to them, because they can make a buck, because they're ideologically opposed to the idea of someone having a good time, because they hate people of color. Take your pick. But we need to be consistent and dig in around this because we're losing thousands and it's completely unacceptable.
Oh, that's going to be a hard act to follow. But Nick, what
Woo!
are, in your opinion, what strategies lead to or can lead to the success of safe supply?
The first thing we have to do, like I spoke about earlier, is the very first thing we have to do is have parity between buprenorphine and methadone. Any door we open for buprenorphine, we need to open for methadone too. We also need to strike down this harmful myth of diversion that we talked about earlier. You know, when we know that is absolute bullshit. You know, we need to stop thinking of diversion as a dirty word, anyways. Considering most of that diversion is for oh, I forget how to say that. It's a community between in and drug users just helping each other out. It has nothing to do with gaining money for a substance. It's usually just to help somebody get well for the day. You know, what we need to do is set up this as a safe supply. And when things like that happen, diversion happens, we need to honor that what that is it's an access to the medicine needed, so people find anything to supplant it. You know, all that means is that we're not doing the job, you know, or that someone's not doing their job. If methadone has to be diverted, then there should be another clinic there, so it's not diverted. Or excuse me, not another clinic, but another doctor being able to prescribe it. You know, we need a short, and eventually we'd hope for a shorter acting safe supply, something different. Personally, I don't think I mean, this is just my opinion, but I don't think we're gonna get anywhere until we first of all, deal with the genie that's already out of the bottle. So we already have a fentanyl risk environment, right? We're not taking care of people when they come into the clinics. A person walks into the clinic, they get set on like 20 or 30 milligrams of methadone. They do not get well for weeks. So they use just a little if they can hold on. But that starts the process off real shitty in a motherfucker. You know, like you start off with, oh shit, I gotta augment my dose with fentanyl because they're not doing anything. Under any other medical situation, if you had fentanyl prescribed to you and then they had another drug, they would have to titrate you off fentanyl even while they're gradually moving you up on another drug. But because we're not we're in a tertiary, as Katie said, healthcare system, they don't do that to us because we're not worth that. You know, they don't have those conversations, and they'll tell you liability, and they'll tell you this, you know, and they'll tell you it's this, that, or the other. We'll figure out a way. You find a way to make it the most confined drug in our history. I'm sure you can find a way to unfuck it, you know? So, I mean, at the end of the day, that's all there is, you know, and we'll see what comes out as the system gets rattled as much as we can, you know? I think method of safe supply is something that's hopefully open up windows for us to proceed to true safe supply. And I think what Ryan said was real key about that, like one that's rooted in social justice, one that's rooted in, you know, like as Zara was talking about, I know a little bit about what you're talking about, what's going on with the coca plant. We had a friend of ours who was doing some work in that. And, you know, there's all these tribes that are like unified and ready to do this thing to make I can't remember the name of the substance, but I tried it. It was a Mabi or whatever the substance. Yeah. And it's like, here's a substance that you could take that 15 minutes after it leaves your body, you have no side effects, nothing. Like you wouldn't even know it's there. And it's just you're just unfucking the supply chains, you know? So I don't know. I think hopefully we're right for drug legalization and we'll get a different safe supply. But for now, at least we could unfuck this, you know?
Kali, do you have something brief to say in response before we ask Zara to finish off the question?
Yeah, it's just, can you hear me?
Yes.
Okay. It's about the system. It's about not having where it's like some versus opioid users, like it really needs to come together as one and just allow that chain to happen. It's just like having the split is just like challenging and difficult, and it's such a heartbreaking thing because it's always there's a hierarchy when it comes to drug use, and it sucks, but we really need to stop that and just come back to be all drug users because we're all drug users, not just have this hierarchy of opioid users versus stimulant users all the time.
No, that's a really important intergroup consideration. Zara, do you have something to end this question on around the topic of the continuum from production to consumption?
Yeah, I mean, this is a big question. I think it's one of these things we obviously need civil disobedience. I mean, we see what's happening in Canada. We're hugely inspired. I mean, it's amazing what's happening because it's bringing to light, it's showing what's actually going on. And the thing that's horrible is that there doesn't seem to be a political will to change things. Because people keep dying. They keep dying in the United States, they keep dying in Canada, and they keep dying in Mexico because of violence. And because this is all state violence, prohibition is sanctioned state violence, that we can criminalize people for deciding to put something into their own bodies, or people who are helping somebody else be able to gain access to something that they need or want. And so that's where then really we have to think about how are we going to be able to shift this paradigm completely. And there's a lot of questions in there in the question box too about like how do we sell safe supply. And the thing that's really hard, or how do we advocate for these strategies, is that I think we need to be organized. We need to be collectively organizing and going to our legislators and talking about these issues so that they do not feel like we're on the sidelines. And part of that then is having, your speech of what you need to be able to talk about. And then the other thing that Kali was touching on is we need to have a united front. We can't be dividing people by the drugs that you use, because honestly, most of those legislators are probably also people who use drugs. They're just not out of the psychoactive closet or talking about it for whatever reason. And so we really have to think about, I can advocate for drug policy reform around drugs that I don't use. That's totally okay. And so can you. And, and you also need people who are only in the cannabis space to also come out and talk about other substances and be okay with that. So we really need to figure out how we get people together without thinking that it's our substance that's dividing us, but rather that we are all actually advocating for a different system, a system where somebody is going to be able to get what they want when they want it, with information accompanying that, without the need for drug checking programs, because what's there, without the need to be checking on your friends because you're worried about something might happen to them. And from our end, with knowing that the substances are coming from places where people are paid well for the work that went into creating those substances or in producing those substances. And that means, maybe there isn't, there shouldn't be publicity, there shouldn't be branding. We don't need that with a lot of these substances. So it's also a piece of how do we, because I don't want to consume cocaine that's been made in a laboratory. I want it to have been paid well to communities that have been cultivating these plants for generations, who have a connection to it, and to recognize that. Same with all these other, like, how do we really think about incorporating them into this? And that's also, and Caput has done great work. And in the States, there's so many groups that are working on this. And in Mexico, it's really hard because we don't have drug user organizing. It's very difficult to be able to come out and talk about these issues because it's a very conservative society. And so we're getting there, but I would just say we need to continue doing civil disobedience, working together, moving across borders, recognizing that we're all in this together. And from there, be able to think about how are we going to do actions and how are we going to propose legislation that really integrates social justice, that really integrates what does it mean to repair the harm? What does reparation look like for our communities? And I would end there. And there's so many questions. I'm like, how are you going to answer those questions?
Zara, we are actually past time. I will ask just one question in the question and answer box to end the session, which is, do panelists see any connection between the stranglehold of the quote, chronic relapsing brain disease model of addiction and beliefs about how people who use drugs are powerless? Could that also feed into the reluctance to support safe supply and methadone access? The idea that people who use drugs are incapable of making these decisions for themselves and can't be trusted to use safely? Any one of the panelists who wants to address this, please go ahead. Yeah, go ahead.
I can jump in, right? Because this puts me off. We need, like, a lot of that framework comes from this mindset of like, drug users can't do things and stuff like that, but we've shown drug users can and have the willing because they know what's affecting them. They know what's causing the problems. They know what's like friends, and so it's better to have experience in those conversations. And that mindset is always going to be there, and it's going to still happen. A lot of people, dumb people, not dumb people, but just like a lot of politicians believe in following that all times, and what needs to happen is like bring people up that maybe not have those have with people with lived experience is really important, and why we keep bringing them forward because we have the most knowledge, we know what's affecting us the most. And just that framework is just pushing down a lot of things. There's still in people's mindset is that drugs are not good.
So that's about all the time we have today. And I guess, Kali, your response is basically, continue to demonstrate, as we have, that drug users are capable and powerful decision makers by continuing to organize in a powerful and cohesive way, which I think is an excellent message to end this session with. Thank you so much for joining us, and hopefully you'll also join us for the next session in our series on March 14th at 1 p.m. Eastern Standard Time, which will be on user activist perspectives on successes and lessons learned in drug policy. We'll be bringing together a panel of drug user activists with experience in a wide variety of campaigns to discuss their involvement in drug policy reform and harm reduction efforts. And we'll also talk about what drug user-centric drug policy would mean and how we get there, while also addressing the necessary connection to adjacent movements and holistic wellness. And I'd like to end by thanking all of our panelists, not only for their participation today, but for all the work they do. Thank you so much.
Thank you, Katie.
Thank you.
Thanks, everybody. Brilliant discussion. And thank you everyone so much for joining us today.
That was amazing.
Absolutely.
So many
Oh my
questions.
goodness. Thank you
Thank you
so
so
much.
much.
Amazing work. Have a good day.